360 type 2 diabetes patients, 180 elderly and 180 younger patients were newly administered Dulaglutide. I'd like to talk about the result in elderly patients undergoing Dulaglutide therapy. This graph shows changes in HbA1c, elderly and younger type 2 diabetes patients treated with Dulaglutide. You can see over a period of 2 years respectively, the elderly group achieved and maintained an average of 7.2%, while the younger group achieved and maintained an average of 7.0% in HbA1c. 20 elderly type 2 diabetes patients were injected with help from a carer due to cognitive impairment. 3 patients discontinued Dulaglutide due to intolerance. Nocturnal hypoglycemia never occurred. Next, I'll move on the efficacy and safety of Dulaglutide therapy in type 2 diabetes patients who were renally impaired, including those undergoing dialysis. As the table shows, we stratified 3 groups. 71 mild renally impaired patients. Group A, 12 moderate, Group B, and 6 severe Group C. The levels of HbA1c in Group A, B, and C remained at approximately 7%. As the table shows, the average levels of eGFR remained as it was at the start of Dulaglutide therapy. Suggesting there are no change. In fact, as figure 2 shows, there are in many cases variation in eGFR levels. There are no complications due to administration of Dulaglutide. Patients who were undergoing dialysis, 6 hemodialysis, and 2 peritoneal dialysis, and 1 patient who received a kidney transplant were administered drugs weekly. Only 1 patient undergoing hemodialysis discontinued Dulaglutide due to vomiting. In the remainder of renally impaired patients, there are no complications due to administration of Dulaglutide, and the target blood glucose levels were maintained. So, I move to the conclusion. Weekly GLP-1 receptor agonist provides more effective and safer glycemic control in type 2 diabetes patients who were elderly or renal impairment, including those renally impaired undergoing dialysis. In addition to relieving patient burden resulting from weekly injection, the administration of Dulaglutide might be expected to reduce the risk of hypoglycemia and lower the burden of carers in an aging society. It might also be expected to improve the quality of life of patients due to a reduction in the overall burden of taking medicines and reduction in cases of hypoglycemia. Carers' burdens in aiding elderly patients, compounded by a labor force shortage, will also be lessened. The net result could also be a reduction in medical costs. In order to confirm these expectations, we need to conduct further research with a larger subject group. Thank you for your attention.
Thank you.